Good morning. Hello there. I'm very pleased to have the chair for this morning's Veterans Mental Health Conference. So today is the second instalment of the King's 2021 Veterans Mental Health Series, and hopefully some of you will have tuned in for last week. I'm Neil Greenberg. I'm one of the King's Centre for Military Health Research team, and I'm really pleased to be chairing this morning's session. So we've got an action-packed agenda for the next 2 hours, and we're going to run through some interesting talks, and you will all get a chance to provide some questions if you want to. Because this is Teams Live, the questions come in by you typing them rather than you actually speaking them. And if you send those questions in, then we'll be able to sort of moderate them and corral them through, and I'll be able to sort of pose them to the speakers. Just to want to say thank you very much indeed to the Forces in Mind Trust, who have kindly once again sponsored this conference, which is really, really good of them, and we're really appreciative of all the support they've given us over the years. Just to tell you, we're recording the session, so whatever it does get said from the speakers and the questions that get asked will come through, and you'll get to be able to sort of see the recording later on, and people who have signed up but haven't actually attended here will also be able to do that. And you'll see there should be a live question and answer tab which allows you to submit your questions as you go on. We're going to start off this morning with just a little video clip of a lived experienced piece of media by Ben Zisman, who has kindly made this for us just to give a little bit of flavour for what this is really all about. Thank you.
So can you tell me a bit about yourself and your military career?
Right, first of all, my name is Ben Zisman. I joined the Army in 2007 and then became a Royal Engineer. In 2010, in March, I deployed to Afghanistan, which was known as Op Herrick. That was Op Herrick 12, and that was a summer tour. Then I did roughly 5 months of the tour, and on August the 7th, I was blown up in an IED blast with a Danish Panther, which is just a Danish armoured vehicle, which lots of other injuries, but the subsequent injury now is I am now paralysed from the waist down, which is one of the reasons why I was so keen to get involved with the advanced study.
Okay, and can you tell me when you were first approached by the advanced study, or how you kind of got involved with the study?
Like I said, it was 2017 when I was first approached, and it was by one of the other injured soldiers who was in Headley Court. He was working on the study, helping recruit further down the line. That's what I started doing, help them to recruit other participants. And it was just nice to know there was something else to sort of do, and that they were trying to help and keep along with the kind of research. When you finish with the Army's rehab system is amazing, but then you sort of don't know what to do. Then you're sort of not sure what the next step is.
Okay, and can you tell me what did you think of the study when you were first approached?
I was a bit wary, to be honest, to start with. And I was a bit like, I thought it was going to be a very generic study, because a lot of the time you see this is no fault of kind of the system, that within a lot of the rehab system and everything, being an amputee was a very common injury within Iraq and Afghanistan. So obviously a lot of stuff is tailored to that kind of slant towards everything. And this study isn't at all. When they spoke to me, first of all they were asking me was, what did I need? Because it's not that it's more difficult, it's just very different being paralysed compared to somebody with PTSD or who's an amputee. So it was nice to know that it was very tailor-made to me, to what I needed when I was there, whether it be just the physical transfer from my wheelchair onto the board. So that was really helpful, and it just seemed to go in waves. More and more, they were giving me more and more information and more help. So I was really pleased to get there.
Great. And can you tell me a bit about what it's like to be part of the advanced study? So maybe a bit about what it involves, or how you found the experience.
Yeah, so when you first get there, you're greeted from the minute you get there. And most people, when you get there, you're quite hungry, because you don't know how to eat, because I want to give you it's called fasting, which means you haven't eaten since 12 o'clock the previous day. And so you just, and they reassure you very quickly, as soon as taking your blood, we'll give you breakfast, and it's a very comprehensive breakfast, so that's no worry. And then you go through lots of different tests, and the one that really kind of shone out to me was it's called a DEXA scan, whereas a lot of gyms can do this. You can do a minor version of this when you stand up, and obviously, as I can't stand up, I wasn't able to do that. So you can measure your body fat and your body muscle and everything. And they did that, and that was really helpful for me to have that, because there's only about 3 centres in the whole of the UK that can do that to somebody who's in a wheelchair, because you need to lie down. So that was really helpful. And every step of the way, I was asked if I was still okay to do it. You're not signing your life away when you're doing it. It literally step by step. If you want to say, I don't want to do that, you haven't got to do a certain part. It's not all or nothing. And then when I finished, I wasn't just given because they call it an MOT, but it really is an MOT of other things that you wouldn't get normally at the hospital and the doctors. And they explain everything. You're not just given a big booklet and then told to just go. So it was really helpful in that way.
Okay. And how do you feel that Advance has made an impact to your life, if it has, or have you seen any differences since taking part in Advance?
Well, as I say, I went back with them to help with the recruiting process to get people that I might know who, like the same as the lad that got me involved. And that was really good to be involved in that. And I've also got involved with them. They do a newsletter, an emailed newsletter that gets sent out to people. And I was involved with that. And it's good to see what they're doing, how the research is helping, and what people like myself are doing on the study. Because somebody else might be in the same situation as me, and they might see me, and then, oh, I didn't know somebody who was doing that, or the same way somebody who has PTSD or an amputee might see that somebody else is doing it the same as them, and they might feel more comfortable to take part.
Zisman giving his views on how the Advanced study has helped him, which is great, and you'll be hearing about the Advanced study a bit later on. But so moving on, our first presenter is Dr. Kirstie Anderson, who we're really pleased to have here. We saw Kirstie present about a year ago, and I really thought she's a fabulous presenter, and it would be really great to get her on here.
I'm Kirstie Anderson. I work in a big sleep service up in Newcastle. I'm going to share my slides and tell you a little bit about.
You can have me live or my pre-record.
Great. Oh, sorry, we had a bit of a pre-record there, but we're going to get Kirstie live, which is better news. So she's a consultant neurologist and she specialises in sleep disorders, and she works up in Newcastle, and is the author of How to Beat Insomnia and Sleep Problems One Step at a Time. So without further ado, I'd like to introduce her and to hopefully get her live and be able to deliver her presentation. Thank you, Kirstie.
Fantastic. So hopefully live and kicking, but you had my backup audio there. So yeah, work up in Newcastle. We're really interested in the interaction between sleep and mental health. So next slide, please. The most important thing to say is sleep disturbance is not a diagnosis. I hear this all the time. You know, depression is associated with, long list of symptoms right at the end, sleep disturbance. PTSD is associated with, diabetes is associated with. The implication is that the poor sleep is the sole result of the daytime disease, and that really is often not right. My bias is that you can ask a few short questions to pick out the identifiable, treatable primary sleep disorders, the diseases of the night. And we have great therapies. These are under-recognised, under-treated. And the point is, if you move or interrupt sleep for any reason, there's an immediate impact on mood, on memory, on metabolism. Next slide, please. Let's actually think about it. Only 4 things go wrong with sleep, but they are 4 different things. Next, please. Not getting through the day without napping. Now that is different to fatigue, mental or physical exhaustion. Closing your eyes each and every day. By far the commonest cause, really loud snoring, pauses in breathing, obstructive sleep apnea, or possibly your prescription. Very different is a really frustrated, fragmented night, insomnia. It may come alongside other mental health problems, but in and of itself, it's miserable and treatable. Then we have things that go bump in the night. acting out of dreams, sleepwalking. And again, I'm gonna cheat a little bit. I'm gonna put restless, wriggly legs in there as well, a different problem. And finally, you can be out of sync with the rest of the world. Healthcare workers are shift workers, but we have some people set to fall asleep at 3 in the morning, make at midday. It's different. Why does it matter? Well, we did a really careful study looking at patients with bipolar. These are people who all need long-term psychiatric care. And actually, a set of questionnaires, melatonin profiles, accelerometry, we could clearly pick out very specific sleep problems. Next, please. The most important thing is, and you don't really need to look at the detail, they were not all the same. Some had obstructive sleep apnea, got loads better with a CPAP machine. Very few had true measurable insomnia. That's important to say. And the really big deal, and there's 3 papers published on this in Psychological Medicine, next please, is that if you looked at people who had poor sleep, and that was about half our sample, they had significant problems with all of the memory tests. If you looked at people without poor sleep, next please, all of the memory tests matched our controls. And we looked very carefully at medication, at mood state. The single predictor of not really being able to function in the day was poor sleep, not the bipolar itself. So I think sleep's a big deal for that reason. Next, please. This patient, and you don't need to know much about brain scans to see the great big white thing, was hit round the head, traumatic brain injury, a significant trauma, and he went to our rehabilitation hospital. And the problem was he couldn't do his rehab because he was groggy and sleepy all day. After a bit of thought, they did a very simple screening questionnaire, something called the Stop Bang. Next, please. Now you can do this on yourselves, you can Google it. These are very simple questions. Do you snore? Are you tired? Do people see you stop breathing? If you score 5, 6, 7, 8, you are really likely to have obstructive sleep apnea. So the lovely thing about this is, and it was even before COVID, we sent out a home sleep test. The rehab staff put it on. Next, please. And what we could see was that there were big, long pauses in the overnight breathing. Lots of good reasons. Medication that relaxed the upper airways, some weight gain during the time on the rehab ward. Next, please. A beautiful, simple, remote now CPAP device stopped all the pauses in the breathing. The current devices are wireless monitored. We've been able to run almost entirely remote during COVID. And so when people ask me, you know, what's the tips to sleep well? When I used to go to parties before COVID, people used to ask me that all the time. My top tip to sleep well, next, please. And next, please. It's a really good idea to keep breathing. I'm doing it effortlessly at the moment. If you stop breathing at night, it's the single biggest reason you will have a horribly fragmented night. And most people just are not aware of having this problem and are blaming grogginess and fatigue on other daytime diseases. Next, please. We need to think about tablets. People still come to me and say, I am not sleeping well, what can you give me? And I always look down the prescription and my first thought is there anything I should be taking away? I'm always reminded that heroin makes you feel heroic. It was actually marketed as a cough sweet with a genuine feeling that this would be a safe, effective thing to give people coming out of the TB epidemic. It was well-meaning. And this graph at the bottom with the red line again reminds me that with opioids, you are far more likely to accidentally die, accidentally be admitted to hospital with overdose or sedation now on a prescription opioid rather than, for example, heroin. That's a shocking statistic, and unfortunately up in the northeast worse than other areas of the country. Drugs prescribed in good faith, and then we also add a group of drugs that all have the word GABA somewhere, pregabalin, gabapentin. These are drugs that are very good for nighttime sleep, The slow wave sleep, those big slow waves, they increase that. But actually, if you take them during the day, they are going to make you feel groggy, sedated and dizzy often. So next, please. We did a study looking at the biobank cohort, about 500,000 people, and we carefully separated out all sorts of tablets and medicines this group were taking. And drugs like morphine, oromorph, gabapentin, pregabalin are not only bad for sleep, they're actually bad for your waistline. They have a really big impact on obesity, on weight gain, as an independent risk factor. And of course, if you gain weight, that's going to increase fatigue, it's going to increase joint pain. So you need to think about the prescription and whether it's part of the sleep problem. Next, please. Nightmares. Now, I think it's fair to say that many people, when they hear about horrible, violent nightmares, and just read down these two stories. These were two patients who came to see me 10 years ago now. Very different people. And in fact, one had been exposed to military trauma in the past and very much thought that was part of the problem. Violent acting out of dreams, thumping and hitting and really hurting the bed partner. What I knew was that this was not PTSD, or both of those patients thought that might be the problem. In fact, what we did with that story, a progressive dream enactment behavior, we brought them into the sleep lab, and we could see that within their dream sleep, you are meant to be paralyzed during dream sleep. The brain sends a very powerful signal to switch off skeletal muscle tone. We could see bursts of muscle activity coming through. On the red line, it should be a flat line, and where the big blue arrow is, this burst of activity, they had REM sleep behavior disorder, and the point is it was treatable. And it was easy to treat with a really good effect. They could sleep safely in their beds again. So again, just thinking about different causes of sleep disturbance, not blaming it on the daytime. Next, please. Now, this is different. This is someone who'd had awful prior trauma with the most unpleasant and miserable nightmare. And you think what to do? And again, I am often asked to think about prescription. Next, please. I'm just going to highlight that some of the psychological therapies for nightmares are exceptionally effective. I think there's a real tendency to undervalue psychological therapies and overvalue drugs. So we, as a routine part of our service, people with horrible nightmares for any reason would go through imagery scripting, image rehearsal therapy. We can teach other people to do it. We have annual sleep training days. And I was part of a group that put together a consensus statement. This is a freely available paper. And image rehearsal therapy has a powerful evidence base. It is simple and effective if you have recurrent dream themes. Next, please. This is one of the most powerful studies I know, a really good quality randomized controlled trial looking at sexual assault survivors with PTSD, showing that with the intervention of imagery scripting therapy, you could have improved sleep quality, decreased dreams, decreased distress, and really this was a sustained outcome over months. So it's important to think about targeted therapy for specific sleep problems. Next slide, please. Insomnia. Now, always said to be the commonest sleep disorder out there in primary care. I'm going to be really niggly about my definitions. This is trouble falling asleep, trouble staying asleep, feeling that that's your main frustration during the day, and it's got to be most of the time for at least 2 or 3 months. And I always talk to people about the two different bits of how do we control sleep. We've got hours, the mythical 8 hours that does not really exist. Most of us over the age of 30 or 35 sleep 6 or 7 hours if you measure it objectively. But we have a pressure to sleep with every hour of wakefulness, and then a switch flips. But we are hardwired to light. Superimposed upon that is a design where we are awake in the light and we're asleep at night. And the other thing I always explain to people is that this ebbs and flows over the course of the night. Nobody sleeps through. Really important to say that. Everybody wakes, but it's whether or not you remember the wakening frustrated by it. And because you have these two circuits, in fact, your most wide awake 2 hours are just before bedtime. So you can already see that if you start to chase sleep, if you get into bed 2 hours earlier because I didn't sleep last night, you start to make the problem worse. Next slide, please. So we know how you should treat insomnia. And it's so important to say, if you have a real frustration with your sleep, the techniques that we use, CBT for insomnia, CBTI, absolutely work alongside other physical or mental health problems. So if that's your main source of distress, having another mental or physical health diagnostic label does not stop the treatment being effective. So we take people through about 6 hours over about 6 weeks with a sleep diary. We go through the absolute nuts and bolts of sleep. We start to look at the maladaptive behaviours. It's not anyone's fault. I understand why people do it. And we have a very big effect on taking those frustrated awakenings out of the night. We can teach anyone to do it, and it does really work whether you deliver it in groups, whether you do it online, whether you do it face to face. But you might imagine during COVID, there was an absolute explosion of use of online therapies. So I'm just going to flag up, there are 2 validated programs in the UK at the moment. There's plenty of others across the world, and there's more coming, but we have SleepStation and Sleepio. At this point in time, although the contracts may change, SleepStation is available to GPs in England within the electronic referral system. But we did a paper looking at the people sent in for the online therapy, and we showed that at least half actually had another sleep disorder. So the most important thing is that this is not Netflix nights, it's not inadequate opportunity to sleep, and probably one of the biggest mimics is wriggly, restless legs. Very simple, effective help that you could get from GP for restless legs, and someone like me if the restless legs are really severe. Next, please. Hospital beds. We're really keen on looking at inpatient sleep because for many people who have poor sleep, actually it started around a hospital admission, sometimes around the time of trauma. So we did a very simple study. We looked at light noise levels in our inpatient psychiatry wards. We showed 2 things. One, that absolutely nowhere in the hospital is it anywhere as light as anywhere out of the hospital. The study was done in Newcastle in November, which, you know, isn't the Costa del Sol. It is 11,000 lux outside now where I am. It is 200 lux wherever you are sitting. This is a blind site. The huge impact on mental and physical health from simply being outside is lost when you are literally pinned to a bed. We also showed that the overnight observations done again, you know, often in a well-meaning fashion and sometimes hourly on a psychiatry ward, were really destructive to sleep. So how could we fix it? Next slide, please. We did a pilot. This is a good-looking pilot. Our pilot was not as good-looking as this. We did the Sleep Well pilot. We got a logo, so then it was a thing. We made a 9-minute video. It's freely available. Smarter Sleep, you can Google it. This 9-minute video decreased hypnotic sleeping tablet prescribing by 1/4, just showing it to about 100 prescribers in the trust. We brought in estates, we screened for sleep disorders. This has all been published. Next slide, please. We showed that you could safely protect sleep, that you could think about sleep as a tool of recovery. This was a universally positively accepted intervention, which isn't often the case with a very distressed, very unwell, very agitated group of people with a huge amount going on. So the comments were absolutely fantastic. It was something I was very proud to be a part of, although many, many other people helped with this. And we have now, as a UK first, got this accepted as a change in the trust observation policy, and we're rolling it out across the NTW, one of the biggest mental health trusts in the country. And we've moved on to teen sleep well. Teenage brains are different, their sleep is different. So that's the next thing we're doing. Next, please. So, final thoughts. If you're sleepy, a little heavier than you should be, over 50, think about your tablets and think about asking somebody else if they've ever heard you snore. If you have a frustrated, fragmented, wakeful night, think about CBT for insomnia. Very different to other psychological therapies. Many of the bumps in the night have very effective therapies. Don't always blame them on the daytime disorder. And sleep disturbance is not a diagnosis. Final slide, please. The people who've inspired me, and the reason I actually got involved in some of the sleep disturbance work, Russell Foster does an amazing TED talk on sleep. Go and listen to it. Fantastic. But the person you don't recognise and will not know, Kelly, the registered mental health nurse there, change is hard. It's all very well me saying don't go in and check on people on an inpatient ward. She was the first nurse to switch herself from day to night shift to safely start protecting sleep. And I am very, very grateful for her time and yours. Thanks very much. Thanks for listening.
Great. Well, thank you ever so much, Kirstie, for a really, really interesting and enlightening talk. We've got just a couple of minutes for questions. We've got a panel at the end just for everyone to remember, so we'll be able to have all the speakers back to do that. But just to keep us on time, we'll just take sort of one question to start now. So actually, the next talk, Kirstie, is on the use of Lariam, which we won't speak too much about that because that's obviously the next talk. But just generally speaking, you mentioned medication absolutely can interfere with sleep. Are anti-malarials something that pops up quite a lot in terms of sleep disturbance? And can you say a little bit about that?
They really aren't. If I go through the common drugs that, you know, week in, week out, I might suggest people de-prescribing. I might go really simple and say nasal decongestants contain adrenaline, inhalers. So although you might say, you know, what do you, I see we see about 2,000 patients a year, 2,500 new patients. It really isn't something that comes through a signature within the NHS. Now, of course, there's different people with different expertise speaking. And I think we'd always have to look at the whole prescription. And, you know, very much what was happening around the time that you took a tablet. That would generally be my approach.
Great. OK, well, we have got, that's fabulous. We've got just a couple of minutes just for, so we've got one more question. In terms of mental health problems and sleep, is there any sort of link between sleep being an early indicator potentially for mental health problems that people might be developing?
Absolutely. And I mean, you know, I'm clearly simplifying. There's very expert psychiatrists talking. It is, of course, a bidirectional relationship. You can talk to people with bipolar. Absolutely. It's their very first warning sign just as they tip into psychosis. And they learn that. And in fact, sedation and controlling sleep makes a big difference. But equally, we flip it the other way and people have well-treated depression, but have awful residual insomnia. And if you improve the insomnia, you decrease their risk of future relapse. So is that
great? OK, that's absolutely fabulous. Thank you ever so much indeed. That was really useful. So we'll have a chance if anyone has any more questions for Kirstie to ask her those at the panel stage, which is at 11:45. So we're a minute early, which is always good news. So I'm really pleased to introduce our next speaker, who's Professor Ron Behrens. Ron is an honorary consultant at the Hospital for Tropical Diseases, and he ran the first NHS clinic for the Hospital for Tropical Diseases from 1989, so quite a few years ago now. And importantly, he sat on the Public Health England's advisory committee for malaria prevention for the last 20 years. And for those of you who are interested in military mental health, you'll probably hear that from time to time Lariam, which is also known as mefloquine, it's an anti-malarial, comes up and indeed has been a topic that the Defence Select Committee have also considered over time. So there are lots of debates about it, and I'm really pleased that Ron is here to sort of give us some detailed expert insight into Lariam and the military and mental health. So thank you very much indeed. Over to you, Ron.
Right. Good morning to you all. Right, this is a controversial area, and I'm trying to keep it as objective as I can. My declaration of interests are there, and I've acted as an expert witness on this for a number of groups. Can I have the next slide, please? So we'll start with a bit about the drug itself, mefloquine. It's a synthetic quinone methanol, developed by the military, the Walter Reed Army Institute in the 60s, developed through the Vietnam War, and then marketed by Hoffmann La Roche in collaboration with the WHO. And it's a very effective drug for killing and preventing chloroquine-resistant falciparum malaria. And when it was introduced in the late 80s, early 90s, it was a sea change from the chloroquine and proguanil, which was beginning to fail, both in therapy and prophylaxis, so a big improvement. It was licensed for treatment and for prophylaxis, but it was found that in the doses used for treatment, it had significantly more side effects, and therefore has been very limited use as a treatment, but widely used as a prophylaxis. Now, the problem with doing research into anti-malaria prophylactic drugs, they're easy to do in country where malaria is endemic, but in traveling populations, they're much more difficult because it is very obviously difficult to supervise and monitor travelers in studies, and therefore there are a limited number of traveler studies, but there are many more military studies because they are a sort of supervised, monitored group, and therefore studies are much easier. So there are many more studies in the military populations than there are in travelers. Can we go to the next slide, please? So I'm mainly going to be talking about the adverse events of mefloquine because clearly it works effectively in its main role as a prophylaxis. And there are different types of adverse events, and I'm showing you here that what an adverse event is basically an unfavorable or unintended symptom or sign from a drug. But it's also to understand the contemporary nature of these events. And we talk about concurrent events, those are events that happen while you're on the drug. We also have occasionally latent events, which are not apparent when you're taking the medication, but are shown to be related at a later stage. And finally, there are the persistent ones that arise when you're taking the drug, but also persist for longer than 20 days after you've stopped the drug. It is important to understand that the drug itself has quite a long half-life of about 13 to 14 days. So it's in the blood for quite a long time, which is why as it has the advantage of only being taken weekly, whilst many of the other drugs you need to take daily because of their shorter half-lives. And being a long-act or long retained medication, some of the effects can last for much longer because of that long half-life. Next slide, please. So in the summary of product characteristics, the data sheet, mefloquine has the listed side effects or symptoms associated with. And interesting from the last talk, insomnia and abnormal dreams and nightmares is one of the most frequent, and certainly in concurrent use when you're taking the drug, that's the one that most people report to me, that they've had bad nightmares and dreams whilst taking the medication. And that occurs in up to 20 to 30% of users of the drug. But there are many others, and there's anxiety, depression, restlessness, confusion. In 2013, the SPC changed its advice and suggested that any of these signs were a prodromal event for a more serious neuropsychiatric event. And that's an important statement because it suggests that if you have any of these signs, including sleep disorders, you may, they suggest, get more serious neuropsychiatric events. Also, the contraindications of the drug are what I think somewhat ambivalent, where you have a history of psychiatric disturbances, but they don't say what the psychiatric disturbances. For example, is it sleep disorders? They give some examples, depression, anxiety, and schizophrenia, but it's somewhat ambivalent in the SPC. The problem that many of you will recognize, next slide, please, is that many of these symptoms that are described with mefloquine are common symptoms associated with the general population. This is a study of psychiatric morbidity in the general population by the Office of National Statistics. And I'm sure the previous speaker will agree that sleep problems are one of the most common, but fatigue, irritability, depression, and anxiety are all common in the general population. And therefore, the challenge with examining and exploring mefloquine is, are they random events or are they related to the drug? And this is where the challenge of dealing with mefloquine is it a causal, or is it an association, or is it just a background effect? And we can try and explore that to find out what is the evidence. Because it's such a large subject, I'm not going to look at concurrent adverse events, but I think there's clear evidence that concurrent adverse events are associated with the drug, and these tend to be insomnia, abnormal dreams, nightmares, acute anxiety, and those are the more common ones. But what about the latent or persistent? And that's where the challenge is. So can we go to the next slide, please? I thought I'd also give you a bit of a background to the situation where we are today. As I've said, the drug was originally licensed in the late 80s, early 90s. But in the mid-90s, there was quite a lot of litigation around Lariam. Watchdog program made a news program or a user affairs program made a statement that Lariam was causing huge problems, and a large litigation group took action, but they had their funding withdrawn in the 1980s. And then in the United States, there were some events where, for example, a soldier killed some colleagues and associates and this was blamed on the fact that the soldiers had been using Lariam. And this resulted in the United States commissioning a research into the effect of Lariam, and subsequently there's been a lot of reviews, committees looking at the role of Lariam in neuropsychiatric disorders in the military, and I've listed many of them, and we'll talk about some of them later on. The largest studies to examine this were mainly commissioned by the US military. They are as effective studies as can be done within their circumstances, and I'll talk about those in a later date. The most recent analysis was done by the National Academy of Sciences of Medicine and Sciences in the United States, and I'll talk a bit about that at the end as well. So that's the spectrum of where we are today. The other point I want to make is that the European Medicines Agency changed the data sheet for Lariam in 2013 to suggest that it was the neuropsychiatric were more serious than had been shown previously. Next slide, please. So I'm going to start by looking at what is said against Lariam, and one of the biggest critics is a doctor called Remington Nevin. Next slide, please. And you can read what he says. This is in a chapter he's written about what it causes, and it's toxic encephalopathy. And he talks about chronic effects. He talks about brain damage. He talks about toxicity of the limbic system. He talks about mood disorders, personality change, psychosis, and so on. So he has a huge range of issues with the drug, and he has founded a pressure group called Kunism Foundation, which is against mefloquine and other quinolone drugs, because they think there's a chronic encephalopathy related to their use. Next slide, please. Of importance, though, he says that many of in the military, the disorders of PTSD may be mefloquine related, and he says that it's not being recognized that the link between the two is that the mefloquine may be the cause of the PTSD and confound the diagnosis. Currently, there are a number of Lariam action groups who have various litigations and compensation claims, and I just use one that I found on the web, but certainly there are a number of groups who are trying to support claims from soldiers who have very many of the symptoms that I've described. Next slide, please. So I'm going to, because of the time, I'm going to summarize some of the best studies that we have available, where there are comparison groups. There's a clinical diagnosis, there are large sample sizes, and there are other covariates included, such as deployment and non-deployment and gender and so on. And just give you what the evidence that I see exists, and then summarize at the end. So next slide, please. So one of the biggest studies is, again, from the US military. It's a retrospective study in active members. You can see that they've looked at deployed and non-deployed military personnel, and using a number of drugs such as mefloquine, atovaquone, progonal, that's AP and doxycycline, and they were looking at neurologic and psychiatric disorders. The next study, next slide please, is again from the US military. This was an earlier study. It was mainly looking at hospitalization of military personnel, looking at their diagnosis and looking at their what they've been prescribed, and making comparisons between active duty members and non-active members. And again, looking at a whole range of neuropsychiatric events. And again, the numbers here are large. Next slide, please. And again, a more recent one, looking at the chronic neuropsychiatric events in, again, large numbers of US military, looking at deployment, looking at the drugs used, and so on. And again, they're looking at chronic disorders. I'll summarize their findings when I've gone through all the studies. Next slide, please. Then there are two UK-based studies. These are based on the UK General Practice Research Database, and they look at individuals who'd been prescribed antimalarial drugs and then who had a diagnosis in the future of a neuropsychiatric nature. And so again, there were quite large numbers of them, and there were two similar studies done in different periods, again, looking at subsequent diagnosis to the use of an antimalarial in primary care practice. And the final important study, I think, is a Cochrane review, next slide please, which looked at, it was a very large study, but I just wanted to highlight that they looked at the drugs effect with the military and non-military. And what was interesting, of course, in this analysis, they found no difference between the military and non-military prevalence of side effects and discontinuation of drug, suggesting that the way the population behave is not necessarily entirely dependent on their jobs or the type of persons they are. What were the main findings? And again, I really had to summarize a huge amount of findings. So can we have the next slide, please? In the ICOS study, next slide, please. The summary is that mefloquine users had similar neuropsychiatric events to doxycycline and atovaquone progonal. And what was interesting in this study is that in some of the military personnel who had psychiatric illness, they did not have a higher rate of psychiatric disorder subsequent to the use of mefloquine, which is what the contraindication of the drug says you shouldn't be given to somebody with neuropsychiatric disorder. But it appears in this study, and there were quite significant numbers, it didn't exacerbate their underlying diagnosis. Next slide, please. In the WELL study, which is mainly on hospital admissions, next, please. Mefloquine users were at decreased risk of hospitalization and mood and severe mental health disorders. Next slide, please. And in the Schneiderman study, I think this is an important one. Next slide, please. They only looked at chronic morbidity, and they find, which I'm sure most of you recognize, that combat and deployment were the main contributors to mental health outcomes and not the antimalarials or mefloquine. And this was really also identified in ICOS, that it was the deployment, not the drug. In the two GP, the general practice database studies, next please. Mefloquine was not associated with increased depression diagnosis in either cohort analysis or in case control analysis. So compared to all the other antimalarials, there was not an increased chance of being diagnosed with depression or other diagnoses. Next slide, please. And this one, as I've already pointed out, next, please. The main finding from the Cochrane review was that mefeprin was not shown to have more frequent serious effects than the other drugs, but the evidence was low. Next. But we know this from the original studies that they are more likely to have abnormal dreams and insomnia and anxiety whilst taking medication. Next, please. So, other than the research, there have been a number of groups who've been looking at the relationship of mefeprin and the military, and this is an example. And so from the Australia on the top left, the Australian Parliament looked at it, the House of Commons here in the United Kingdom looked at it, the American Office of the Secretary of Defense in the Senate looked at it, and the Canadian military, Surgeon General and Parliament also looked at mefeprin in the military. And these reports are quite extensive, except for the House of Commons Committee, which was very small. And the one in the middle, the consensus report from the National Academies of Sciences, is probably the most comprehensive. Next slide, please. Their final summary is listed here, and they find that there was no current evidence or inadequate evidence to show an association of mefeprin and persistent or latent neuropsychiatric disorders, including PTSD. But they suggest that the evidence wasn't good enough to make a stronger link, and there is some suggestion of biological plausibility, and they require bigger studies to actually answer the question, is there an association between the drug and latent psychiatric disorders? Next slide, please. So, in summary, this drug has been extensively used, but now is much less used. There's been quite a lot of epidemiological research in the military into latent and persistent disorders. To date, those have not been identified in relation to the use of the drug, but the evidence that we have is not necessarily good enough to make that determination. However, because of its reputation and its public perception, this drug has been either been withdrawn from markets or certainly been reduced, and there are very few organizations and military now using it as the first-line agent, and therefore it is very unlikely that the question will ever be answered. So we are left with what we've got, but we can't answer the question. But currently, there doesn't seem to be a strong association. Thank you very much.
Great. Well, thank you ever so much indeed, Ron, for covering what is, as you quite rightly said, a sometimes controversial topic. We've got a few questions, which I will do, but I will take Chair's prerogative to ask the first one, which is perhaps one that you might have a view on, but it could be open for debate. Is given that what you presented is that the evidence on Lariam doesn't tend to suggest it's as demonic a drug as many people claim, why do you think it is that it's ended up with this kind of reputation as being a neurotoxic horror drug, and people are very, very keen that it shouldn't be used when the evidence doesn't necessarily support that?
I think it comes down to my second or third slide when I showed many of the symptoms associated with frequent symptoms in the population, and people then attribute it to the drug. And if it can cause insomnia and depression and vivid dreams, why can't it cause longer term neurological disorders or neuropsychiatric disorders? And that presumption, I think, is part of the problem. I think also in the groups that are most disturbed by it, or the military, they have other disorders which will have developed whilst taking the medication. And again, I think there's an attribution to the drug rather than the other environmental or occupational risks that they face. And I think these get conflated. And the mefeprin story makes me think of the autism story and the MMR vaccine. And I think the population or the users want to be able to blame some product to their psychiatric disorder, and a drug is as easy a thing to blame as possible. And that's my own personal feeling on it.
Okay, great. Well, thank you very much. So just got a few questions now, which the audience has sent in, and I'll kind of conflate the first two together, which is about, really when were the first side effects of Lariam as being indicative of more serious things? When were they first known? And someone's written, for instance, why did the World Health Organization warn and not advise the use of mefloquine, Lariam, in 1989 when it was first licensed? So,
well, the problem was that study was just spontaneous random reports, and they weren't necessarily indicative of anything. There were about 1.2 million doses prescribed, and there were a couple of hundred severe neuropsychiatric events. Now, the problem is that because of a new drug, you're more likely to report an event, and whether it was causal or not could not be attributed, but they published it, and then people said, well, there must be a link here, and therefore from there it's sort of developed, I suspect.
Okay, well, thank you for that, and I think that's interesting. One of the other questions later might sort of touch on this. Someone's asked if Lariam does cause damage to the brain, if it were to, might that show up on some sort of brain scan?
So there's been a lot of work done on that. There's no evidence from looking at anatomical investigations of brain damage. There's some rat work when you give large doses that the rats have some changes and behavior changes, but if those can be attributed to humans, a lot of people don't think so. The drug, once it's eliminated from the body, it's felt is unlikely to be causing the current symptoms. And so the decision is there is currently no scientific evidence that it causes physical or anatomical damage to the brain. Therefore, to believe that the other point, of course, it may bring to light a pre-existing condition, and that's what a lot of people believe, is when you take it and you've got a pre-existing, you might bring it out, or the travel itself might bring it out.
Okay, great. And so I guess someone's written I think a great question is what does Professor Behrens think are the main lessons we can learn from the Lariam story and associated research? And I might just add my spin is that, if we come up with a new drug called amazepine or whatever that amazepine does, what could we learn from Lariam about the way to make sure that amazepine gets a rightful place in being prescribed when it should be?
That's a really tough question in a drug like an prophylaxis, because you've got to study people out of their normal environment. And I think that to prevent this from happening again, you've got to have really large studies in people in their normal occupational and travel risks, and taking into account their background morbidity and morbidity and neuropsychiatric morbidity, to ensure that this drug is not causally linked to these sort of what I call nebulous, when I mean nebulous, that they were difficult to diagnose psychiatric phenomena. And it wasn't done in the original studies because of, as I say, the design to follow, few thousand travelers across the world. You cannot exclude it. I mean, there have been some interesting studies of mefloquine when taken at home, and they have much fewer side effects than when people take it when they travel. And that suggests, a bit like the work on deployment, that the changed environment has an important contribution to your neuropsychiatric health. And taking that into account in a prophylaxis is going to be very important.
Great. Well, listen, thank you very much indeed. It's been a really enlightening talk, and as you say, with these difficult subjects, it's good to have someone who's expert in the field talking about it. So we're going to move on to the next presentation now, which is on the advanced study. And you heard Ben talk earlier on in his lived experience piece about his experience of advance. So the two speakers for this, the first is Professor Nicola Fear, who probably doesn't need any introduction, but I'll introduce her briefly anyway. So Nicola has been part of the King's team since 2004. And since 2011, she's been one of the directors of the centre along with Simon, and took up her chair in epidemiology in 2014. And also we've got Dan Dyball, who is a PhD student. He's been with KCMHR for a long time, and he's looking at the advanced study as part of his PhD. So over to you. Thanks for your presentation.
Thanks, Neil. Can you hear me?
Yes.
Brilliant. And can you see my slides?
Yes.
Perfect. Thank you. Well, good morning, everyone. It's a real pleasure to be able to contribute to today's session. Slightly different to our usual conference, but great that we could go ahead anyway. And I'd like to start off by thanking Ben for sharing his experience and insights into the advanced study, which Dan and I are going to talk a little bit more about now. So as Neil said, we're going to do a double act, and we're going to talk about some of the emerging findings from advance, particularly focused on mental health. And just before I move on, I'd like to kind of acknowledge that the advanced study is a collaboration between the Ministry of Defence, Imperial College London, and us at King's College London. So the UK has a long history with Afghanistan, but we're really focusing on that most recent conflict, Operation Herrick. Here we saw over 150,000 UK military personnel deployed to Afghanistan. Unfortunately, over 450 personnel died during that operation, and we had a number of personnel who were either very, very seriously or seriously injured, and that's physically injured. Now, in the past, many of those seriously or very seriously injured personnel would have died. But due to advances in battlefield medicine, we've seen increased rates of survival. And this is where the advanced study comes in, because we don't know very much about the medium and long-term outcomes of these individuals. And so the advanced study was established to follow up those individuals who were seriously or very seriously injured at various points in time to look at their physical and mental health. If we look at literature that has already been published, and most of this does come from the US, and a lot of it is based on individuals who were injured during the Vietnam conflict, we see that there is a suggestion that those individuals who are physically injured are at greater risk of mental ill health. And so that's the question that we really wanted to try and answer with the advanced study. Are those personnel who are physically injured as a result of deployment activities at greater risk of mental health problems than their uninjured counterparts? So a little bit about the advanced study. I've mentioned that it's a longitudinal study, so this gives us the ability to follow people up at various time points. And we've got two groups of individuals that we're interested in. Those individuals who were classified as injured as a result of their deployment, and then a group of individuals who were deployed at the same time, to the same place, they did the same role, but who did not experience a physical injury during their deployment. So we've got these two groups that we're following up. Now the participants were, or the potential participants I should say, were identified by Defence Statistics, part of the Ministry of Defence, and then the team, the advanced study team, contacted those participants and asked them to take part in the study. And as you heard from Ben, taking part in the study involves essentially a day of assessments, but also, as you heard from Ben, you get a great breakfast, and the individuals will come previously to Headley Court and now to Stamford Hall. They'll get a number of physical health assessments, and they'll also complete a range of measures as part of a questionnaire. And in that questionnaire, we collect a whole range of information on mental health and well-being. Now, I'm not going to go through all of the measures and all of the data that we collect, otherwise I think we'll be here for the rest of the day. But the outcomes of interest that Dan is going to present some results on next are depression, anxiety, post-traumatic stress disorder. We're also looking at post-traumatic growth, and Dan will explain in more detail what we mean by that. And we've also got a number of well-being measures. Why did we select these measures? Well, for a variety of reasons. Where possible, we've used validated measures. And where possible, we've used measures that other studies have used so that we can compare and contrast what we're seeing within the advanced study cohort. And Dan's going to talk about some of those comparisons as we walk through the results. So now I'm going to hand you over to Dan, who will present some of the results.
Hi there, everyone. Can you hear me?
Yes.
Brilliant. Thank you, Nicola. So yes, my name's Dan. I'm a research assistant on the advanced study and also a PhD student. I've been helping recruit to the advanced study for a good few years now. And since we finished baseline back in August of last year, I've been helping look at some of the data analysis. So just a little emphasis there. These still technically are preliminary findings. I don't expect them to change too much, but we will be publishing the final results later this year. Another thing to say, one of my biggest bugbears during presentations is big tables with lots of data that you don't really have enough time to digest. So we've tried to be a bit more visual with what we're presenting here, and straight off the bat you can see here that we have what's called Average Joe, who represents the makeup of the advanced study cohort. So we saw 1,145 military personnel as part of the advanced study, 579 of which were injured and 566 formed part of that comparison group. So they are as close to being like the injured group as possible, but without the injury. So you can see that our average Joe has an Army issue helmet there. That's because 83% of our sample came from the Army. You can see on his arm that he has a single stripe. That's because the most represented group of ranks in our cohort were privates and lance corporals at 41%. Average Joe is holding a gun, representing the fact that 82% of our sample deployed in a combat role. And the slightly most tenuous link, you can see that Average Joe is holding a Tamagotchi there. That's because most of our cohort grew up in the 90s and early noughties. They were around 34 years of age at the time of assessment, which meant that they were around 26 years of age at the time of injury, or for the comparison group, their deployment of interest. So about 8 years have passed since their injury. Nicola, next slide, please. Okay, so what do our injured groups sort of look like? Well, in terms of the mechanism of injury, around 67% had sustained some sort of blast injury, so from IEDs or RPGs, etc. About 12% some sort of gunshot wound, and around 19% something other. So this would be vehicle collisions or falls, things like that. Those percentages won't add up. That's because some people might be part of one or more groups. And for the purposes of our presentation today, what we've done is we're going to give you the overall injured prevalence in our injured group, but we're also breaking it down, and we're looking at our injured amputees and also our injured non-amputees. So in our injured non-amputees, this could be things from burns, those gunshot wounds that I've mentioned before, shrapnel wounds, fragmentation injuries. It's a lot more variety, and then the injured amputees specifically about their amputations. And hopefully you'll understand exactly why we've done that as we go on. So Nicola, please, next slide. So to explain this slide, at the top there, our first stickman figure is our comparison group. So he represents our comparison group, our uninjured group. The fellow just below him with the plaster on his chest is representing our overall injured group. So this includes both our non-amputee injured and our amputee injured. Just below that, we break it down. So we've got our injured non-amputees with the guy with the bandage, and we've got our injured amputees right at the bottom there. So in terms of depression, and this is measured as part of the patient health questionnaire, around 17% in our uninjured group, which is just over 1 in 6. And then in our injured group, we're seeing just under 1 in 4. So in our injured group, there is more depression, likely depression. When we break that down, we actually tend to see that in our injured non-amputees, that there's a lot more. So we're seeing about 1 in 4 people. And actually, when you look at the amputees, they're not exhibiting any significant difference in terms of prevalence of likely depression compared to the uninjured group. Now, we're going to chat a little bit more about that as we go on. But Nicola, if you could move to the next slide, please. Thank you. So in terms of anxiety, and this is measured by the Generalized Anxiety Disorder Questionnaire, we're seeing a similar picture. Now, in our uninjured group, we're seeing just over 1 in 8 people exhibiting likely anxiety problems. And then in our injured group, that's about 1 in 5. And then we break this down again. This difference between the injured and the uninjured group is mostly driven by what we're seeing in the non-amputee group. So just under 1 in 4 people in the injured non-amputees are exhibiting these anxiety problems, whereas in the amputees, again, no real significant difference between them and our uninjured group. So Nicola, next slide, please. So how does this compare with other studies? Well, back in 2003, King's established a military cohort study. Oh,
sorry.
Bit too eager, Nicola. Back in 2003, King's established a military cohort study to establish the effect of deploying to Iraq.
That's not me, just to say it's doing it automatically. So if it keeps doing it, I'll keep going back. Okay,
thank you. Yeah, so the KCMHR cohort was looking at the effect of deploying to Iraq or Afghanistan on the health and well-being of UK military personnel. It's a longitudinal cohort, and the latest phase ended data collection in 2016. So what they saw that around 22 to 30% of deployed serving and ex-serving personnel were reporting probable common mental disorders. So when we're comparing the advanced study to this cohort, we're mostly seeing that our uninjured groups and our injured amputees are much less than what we're seeing in the cohort study. And then injured non-amputees are sort of hitting around that same figure. Why is that? Well, it is actually kind of difficult to compare exactly with the KCMHR cohort. This is mostly because the KCMHR cohort is looking at all the armed forces. It's got much more representation in other services. It's got much more people in non-combat roles, significantly more personnel who have left service. A lot of our uninjured group are still serving, and yeah, there's much more spread across the services. It's also using the GHQ to give you a general measure of common mental disorders, whereas in the advanced study we are looking specifically at depression with the PHQ and specifically anxiety with the GAD. So in the APMS, which is a general population data, we see around 15% of men reporting probable common mental disorders, which is roughly what we're seeing in our amputees and our uninjured group. And in our injured non-amputees, there's a little bit more. So we'll move on to PTSD to save Nicola's fingers there. Okay, so in terms of PTSD, we used PCR. And in our uninjured group, we're seeing about 1 in 10 people exhibiting likely probable depression. PTSD. And in our injured group, that goes up to about 1 in 6 people. Around 17%. And again, same story. We're seeing that this difference is majorly contributed by the injured non-amputees, around 19%, so almost 1 in 5. And the injured amputees, no significant difference to the uninjured, 1 in 10. So if you move to the next slide, please, Nicola. So again, how does that compare with other research? Well, in the KCMHR cohort, serving and ex-serving personnel who deployed to Iraq, Afghanistan had rates of PTSD between 6 and 17%. And in the general population data, it's around 4%. So you can see that in the advanced study, we are seeing higher PTSD, especially when comparing to the general population. And but yeah, interestingly, the amputees, not really any difference between them and the uninjured groups. So Nick, I was half expecting this slide to jump as well, but luckily not. Nicola, if you can move to the next slide, please. Thank you. So far, what have I said? Well, basically, injured personnel do seem to be at greater risk of depression, anxiety, and PTSD compared to our uninjured comparison group. But amputees, for whatever reason, are showing no differences in prevalence amongst these disorders compared to the uninjured group. So why are these amputees appearing to be a bit more of a resilient subgroup in our injured cohort? Well, we wanted to discuss maybe a few of the reasons why that might be and have a look to see whether that does seem to be affecting our groups. So Nicola, if you could move on to the next slide, please. So relationship status. So being in a relationship is generally seen as being a protective factor against mental health problems. So as you can see, there's a small difference between our uninjured group and our injured group in terms of the amount of people that were in a relationship or married. 80% for our uninjured group and about 76%. But there's not really any differences between our injured non-amputees and our injured amputees, so it's unlikely that this is the driving factor for this difference we're seeing between our injured non-amputees and our injured amputees. So next slide, please, Nicola. So then we thought, well, perhaps there's differences in the residential status. Maybe people feeling more alone, they're not getting as much social support. So looking at the residential status and focusing on people that live alone, we see in our uninjured group around 12% of people live alone. Again, it's fairly small, mostly because a lot of our uninjured group will be living on barracks because they're still serving. In our injured group, that's up to around 16%. And actually, amongst our amputees, there appears to be a lot more of this living alone. They're showing a lot more independence than you might think. And our injured non-amputees, not much difference to our uninjured group. So there is a difference there, but it's not likely to be a driving factor in what we're seeing in terms of the prevalence of mental health problems. So Nicola, next slide, please. So in that same sort of vein of thinking, what about social support in general? Well, we had a measure of social support as part of the questionnaire, and that gave you an indication of whether they felt that they had support from family members, from friends, or from like a special person. And as you can see across all 4 of the groups there is no difference. Everybody is sort of hitting around that 90% mark for getting some sort of social support from someone, whether that be family, friends, or a special person, and the general makeup is pretty much the same. So again, social support isn't really the driving factor between the differences that we're seeing. Nicola, next slide, please. Okay, so now I'd like to talk to you about post-traumatic growth. Well, post-traumatic growth is this experience of going through a trauma and for whatever reason experiencing beneficial psychological consequences as a result. So these consequences might be a greater appreciation of life, seeing new possibilities in your future, being able to relate to other people better, having a greater appreciation of your own personal strength as a result of going through the trauma, or spiritual change. Now, both the KCMHR cohort and the advanced study cohort use the same measure of post-traumatic growth relating to deployment to a war zone. Unfortunately, it's not quite so easy as to say this person experienced post-traumatic growth and this person didn't. There is a cut-off point for this measure. However, we were able to categorize the scores that they gave on this measure. So in the KCMHR cohort, for people that deployed to Iraq or Afghanistan, around 10%, 11% experienced no post-traumatic growth whatsoever. Around 24% experienced very low PTG, then 34% low, and 31% moderate to large post-traumatic growth. So almost a third of people were experiencing fairly big post-traumatic growth, just in the KCMHR cohort. In the advanced study cohort, we see that actually post-traumatic growth is being exhibited much more. In terms of no PTG whatsoever, so a score of 0 on this measure, only 1% of people in the advanced study cohort said no post-traumatic growth. And around 10% were very low. And then we see a lot more people in this sort of low category, 48%, and up to 40% in this moderate to large post-traumatic growth. So you'd think maybe that this is it. This is the thing that is driving this difference in the in the rates of mental health, post-traumatic growth being a protective factor in terms of common mental disorders. Nicola, if you can move to the next slide, please. Well, whilst it is, we can see here that our injured group were exhibiting more post-traumatic growth, there isn't much difference between our non-amputees and our amputees in terms of the amount of post-traumatic growth that is being exhibited. So yeah, unfortunately, none of the factors that I presented to you sort of explain why we're seeing that these non-amputees appear to be at higher risk compared to our amputees. But Nicola is going to maybe disseminate and discuss a little bit more about what possible things there might be in some of the future research that we're going to look at to try and explain these differences.
Thanks, Dan. Thanks, Dan. Hopefully everyone can hear me now. So just to kind of finish up, and I'm conscious of time and Neil will be getting twitchy in a minute. So just to revisit kind of our original sort of research question and the idea based on previous literature about physically injured military personnel being at greater risk of mental health problems than their uninjured counterparts. Did we or did we not find the same? Well, I'd say that that hypothesis was partially supported by the data that Dan's presented. Compared to our uninjured group, we did see an increase in our non-amputee injured group, but we found no difference with our amputee group compared to the uninjured group. And Dan's talked you through some of the factors that we've looked at to try and explain that. And there's more that we are doing, investigating the data, trying to understand what may account for the differences that we're observing. And I'm not going to go through each of these now because I'm conscious of time, but the kind of key ones that we'll be thinking about is, you know, the type and mechanism of injury. Does that play a role? What about the extended rehabilitation that our amputees will undoubtedly be having? Excuse me. Is there a beneficial component of that on their mental health and well-being? And what can we learn from that that may be helpful to individuals who aren't amputees but are also injured? And I think the other thing to say, as we just discussed in the introduction, is the advanced study is longitudinal. And at the minute, we're just looking at one point in time. So we do need to follow these individuals up to see how things change or don't change over time and what may be the factors associated with those changes. So that leads us on to really my sort of final slide. We are following individuals up, and the team at Stanford Hall have already started on the first follow-up of our cohort. That was a bit kind of sidelined by COVID, but we're back on track now. As Dan's mentioned, we've already looked at a number of factors, and there's a number of other factors that we want to look at to investigate further the mental health and well-being of this cohort. And we're about to embark on a project looking at the transition of those individuals who are injured and uninjured personnel from military to civilian life. And this is work that we're able to do thanks to receiving additional resource from Forces in Mind Trust. And with that, I'd like to recognise and acknowledge and thank all of the funders who contribute towards the running of the advanced study. Without their generous support, this study would not be possible. And then I'd also like to thank you all for listening and taking time out of your day to join us at the conference. And just before I finish, I'd like to apologise if anyone was offended by the average Joe slide. That was not our intention, and so I do apologise, and please accept our apologies. Thank you.
You're muted, Neil.
Thank you very much indeed for that. That was really useful and a really good insight. And although we haven't got any time for questions just at the moment, I'm pleased to say that Nicola's wrap-up slides actually probably answered quite a lot of the questions that were in the question list anyhow. And we've got the panel at the end. So now coming on to our last presentation of this morning, and you've just seen a duo, and so Howard, not to be outdone, has got a trio of presenters for the next presentation, which is on socioeconomic trajectories for veterans. So very briefly, the three presenters are Dr. Howard Burdett, who is the lead on this, who has published on social economic trajectories of veterans before and is doing the leading on the work on it now. Also, we've got Dr. Danai Serfioti, who's also working on this topic, and Alex Chang-Tave as well. And they've been doing this work as a team, and I very much hope that this will be an interesting presentation over the next 20-25 minutes. So the floor is yours, Howard.
Thanks very much, Neil. I can't see or hear anything. Well, I can't see anything now that I've started sharing slides. Am I audible and visible?
Yes, you are.
Great. OK, thanks very much, everybody who stuck with us so far. As Neil has said, I'm going to be talking about our recent project on socioeconomic trajectories for people leaving the forces. I will say that, as you'll see, this is a very broad study. We can only really fit a very small number of the headlines into this presentation that we're doing now. So please do bear that in mind. Also, please bear in mind that this isn't final. So if I could ask people not to take things forward too far until the report on this is published in a few months by Forces in Mind Trust, who we are very grateful to for funding this research. So this is a study about transition, ultimately. And we know it's about transition from being in the forces to being in civilian life. We know that most people negotiate this successfully, but there are some who do not. The research in this area has been increasing in recent years, but a lot of it is focused on either specific populations or specific outcomes. For example, last time I spoke at this conference, I was talking about the benefits, unemployment and disability benefits drawn by veterans, which, you know, I'm sure there's people who are here who were there last time who will remember what a terribly fascinating talk that was, but focused on a very specific area. And we wanted to here draw back, take a more holistic view, but focus that view through the lens of what causes people to do better or worse in civilian life compared to how they were doing when they were still in service. So that was the overall aims of this. Key questions that we're going to talk about today is, first of all, top line, how are they doing? Are they doing better? How many are doing better? How many are doing worse when you compare their current last recorded civilian outcomes to their in-service socioeconomic well-being, the drivers for this, and in order to investigate factors that drive this, we took a mixed methods approach, which I'll talk a little bit more about in a second. So both looking at quantitative statistical approaches to looking at what are the factors that drive this, but also qualitatively doing interviews and trying to understand the veterans' own perceptions about what they thought was positive and negative and what helped or was a barrier to them successfully transitioning socioeconomically, and also talking more about the experiences and perceptions of veterans and their transitions, particularly in the socioeconomic regard. So things that we'll talk about today and things that were part of the study. On the left-hand side, we have this quantitative statistical part, which will shortly be presented by Alexandra Chang-Tave. And to do this, we drew data from three sources. We drew it from our own cohort data. So that's data that we've been gathering, well, technically we've been gathering from 2004 to 2016 over 3 phases, which takes a very broad base of both military exposures, demographic factors, and mental health, and also these socioeconomic outcomes. We've also very grateful to Royal British Legion for sharing with us the results of their household survey, and with the National Centre for Social Research for sharing with us the findings of the Adult Psychiatric Morbidity Survey, which is a general population survey, but luckily had a marker for service in the armed forces. So we were able to identify post-national service veterans within that as well. And so by using these different databases and these different data sources and essentially combining them, their different populations and different methodological approaches, we hope to take that holistic database oriented attempt. But there's also, on the other side, we did the qualitative parts, which will be presented by Dr. Danai Serfioti. So this was a series of interviews, and we wanted to make sure that we covered as much ground as we could, in particular certain groups that might be of special interest or at particular risk. So we made sure we covered not just the men that make up the majority of the forces, but also women, those people who leave early, and also people who are reservists. And I should be clear, reservists who have also ceased to be reservists. So they are ex-reservists, they are veterans who served as reservists. So before I let the people who actually did the work do the talking, just quickly, how we defined positive and negative socioeconomic trajectory for the purposes of this study. We started by looking at their ranking service, or their last recorded ranking service, and converting that to a socioeconomic classification, the current national statistics socioeconomic classification. Luckily for most people, we also had their current job title now that they were civilians, so we could perform the same conversion on that and thus be able to do a comparison between two equivalent things. So someone who had a positive trajectory under that definition could be someone who was, say, an NCO. That would be kind of an intermediate level socioeconomic classifications. Then became, a white-collar job like a facilities manager. And contrarily, somebody with a negative trajectory could be somebody who was, a commissioned officer when they were still in service, and then became what is considered by the national statistics a more intermediate occupation, such as a police officer, kind of thing that you can certainly imagine veterans doing. Now, there may be some people shouting at the screen right now that, Howard, this is a very reductionist approach to take to socioeconomic trajectory, and that's completely true. I agree with those screen shouters that are hypothetical. And we are cognizant of that. It's necessary to create that kind of reductionist approach for quantitative statistical analysis. But being cognizant of that, we also included that as part of the qualitative part. How do the veterans themselves view their trajectory? We might, from our statistical basis, view their trajectory as being positive or negative. They might feel differently. So that's a question we get into now. We'll talk about more when Danai gets to do the qualitative elements. So I will now call upon Alexandra Chang-Tave, who hopefully is available and unmuted, to talk us through the quantitative findings. Alex?
Yeah. Thank you, Howard. So as Howard mentioned, I will be talking about some of the quantitative findings from our analyses, from our combined sample from all three data sets and from our subgroup analyses. So firstly, just some very key headline findings are that when we look at the employment outcomes of ex-service personnel, we see that the majority are actually in employment after service. There's a small proportion, 4% of whom are in unemployment and 15% who are economically inactive. This also includes those who are retired. In terms of the socioeconomic trajectories, just over half of our sample are actually considered to have had a positive trajectory, so having a job higher in NSEC grade compared to when they were in service. In terms of no change, so people who had the same NSEC grade from in-service role to their civilian grade, to their civilian job, that was 24%, and there's also a similar portion of negative trajectories, so people who declined in their NSEC grade post-service. Next slide, please. So I'll be covering here some of those factors that are associated with the analyses on our main combined sample. So this is ex-service personnel in general. So on the left-hand side of the table, you could see that there's a positive trajectory, and some of those factors that we found were associated with positive trajectories was having fewer childhood adversity experiences. And in terms of demographic, we also found that age was a factor, which I'll also talk about later on in the subgroups. If you're younger, according to the analysis, that you're more likely to experience a positive trajectory, and also higher education as well. So we're talking specifically about degree level education that would help promote that increase in NSEC classification in your job post-service. In terms of negative trajectory, so you can see that visually there's a few more here that we found that were associated with negative trajectories. In our demographic variables, we find that not being in a relationship was contributing to negative trajectories. And conversely to having a higher education positive trajectory, we find that actually having lower education was a significant factor that was related with negative trajectories, as was having financial difficulties and also living in rural areas. And in terms of military factors, we also find that those people who deployed on any operation, such as Iraq and Afghanistan, in any deployment that they reported would have also been one of the factors associated with that trajectory, as was unplanned nature of discharge, which we've also collected some data on from the qualitative interviews, but I won't share too much at this point. And in terms of health, we also find that mental health difficulties, if they've ever had a mental health difficulties, was also associated with a negative trajectory. Next slide, please. So in terms of subgroup analysis, so as Howard mentioned before, from our subgroup analyses, so we're looking at women, early leavers, so those who served less than 4 years, and reservists, ex-reservists. So for women, we find that, again, in line with the main analyses, that women who have fewer childhood adversity experiences are more likely to experience a positive trajectory. And again, those who are younger, so younger women, were more likely to experience a positive trajectory. In terms of childhood adversity factors as well, we do find that men who've had 6 or more childhood adversity experiences are more likely to experience a negative trajectory. And early leavers, so again, if they were younger, they were younger than 45, so younger early leavers were more likely to decline in their socioeconomic status post-service. And reservists, similarly again to the main analyses, we find that higher education contributes to increasing their grade post-service, according to the NSEC classification. And being older also contributes to negative trajectories. So these are really the key highlighting findings for this presentation. I will now hand over to Danai, who will speak about some of the interview findings.
Hello everyone, I hope you can hear me. So yes, I will talk about the qualitative findings. As you see here, these are the key topics we have identified through the qualitative analysis, but obviously due to time restrictions, I'm going to focus on some aspects of the employment transition, the overall socioeconomic cultural adaptation, and one of my favorite sections, participants' reflections and recommendations. So starting with employment transition, next slide. Yeah, so at the beginning, Howard discussed the negative and positive trajectories. But what we've seen through the interviews is that actually many veterans choose, let's call it a negative transition. So they make a conscious decision to choose a lower status jobs, of course, comparing to their rank, or with lower level salaries, such as, for example, becoming teaching assistants or working in charities or becoming truck drivers. And that is because either they feel they can enjoy such jobs, but also be able to offer back to the community, or they felt that at this point in their lives, they wanted to focus more on their personal lives, their families, themselves, and that's why they prefer jobs with less stress and less responsibility. However, we also see positive transition by chance, and by that I mean there were veterans who decided, well, they ended up in higher level jobs, such as managerial jobs, not because they were specifically chasing for such opportunities or such promotions, but it just happened that after they left the military, usually through networking, an opportunity arose, they felt it was good for them, and that's why they moved forward. We have also identified veterans who decided to become self-employed, either because they wanted to manage their own finances or their daily life, daily schedule, and especially for people who had children. And actually some of them were successful and they managed to build a career. Next slide. Okay, so socioeconomic cultural adaptation. These are some of the aspects we have identified. I will start with the perceived facilitators. So the most important thing for veterans was individual preparedness and responsibility, not only during transition and resettlement, but also while serving. It was perceived that this preparation can increase the ability to recognize and effectively use life skills to their advantage, such as leadership and discipline, decision-making, interpersonal skills, and of course, maintaining a positive, dynamic attitude towards employment and life overall. It was also perceived as helping to remain flexible, to remain open-minded, and to all these new opportunities or new experiences that can arise in civilian life. So ultimately, all these factors led to a smoother cultural adaptation and also helped in redefining self-identity. And now moving on to the next slide, which is the perceived barriers. So I would like to start with physical injuries and mental health conditions. So veterans who had such experiences, they explained that these delayed a lot their practical and mental preparation for the overall socioeconomic transition and cultural adaptation. That was because either they had to focus on their rehabilitation and to learn to live with these new injuries or disabilities, or in the other case, they had to better understand what is this mental health condition I have now and how can I manage it effectively in order to move on with my life. So apart from veterans who had these experiences, overall now, following on from what I said before, so not being prepared, not having a plan can lead to the lack of realization of the financial responsibilities of the civilian world, a continuous unhealthy comparison with military versus civilian culture, and of course lack of flexibility to adjust to civilian workplace environments. So ultimately, all these barriers were perceived to limit veterans' options and their ability to identify any positive aspects of civilian culture and enjoy this new chapter in their lives. And of course, this created more challenges in achieving self-identity. And moving on to the next slide, yeah. So this part of the interview was one of my favorites. So these are participants' recommendations for transition services. So what was highlighted by all participants, both participants who had a smoother transition or they didn't face any challenges, but also people who were injured and they had a very challenging socioeconomic transition. There is this need of an integrated long-term preparation. For example, stop spoon-feeding people, especially the younger generation in the military, increase individual responsibility, which is necessary later on in civilian life, financial awareness, housing, for example, how to save money and use money effectively, what do you need to buy a property, how can you invest in a property, and also future civilian employment. For example, all these trades and qualifications that personnel can actually achieve while serving, that then can be useful in civilian workplaces or recognized by civilian employers. So these were perceived as helping everyone, all veterans, to have a better, a smoother transition, but specifically they were considered that they would be extremely helpful for people who are medically discharged and they unexpectedly have to leave the military. And moving on to the next slide. Also continuing with participants' recommendations. So the need for peer support, to establish peer support officially, was considered very, very important, especially for those veterans who are medically discharged. And following on from that point, the need for organized continuous communication with service leavers, at least for a few years after leaving. Again, I want to highlight here that this point was made by both people who were injured, who faced challenges, but also people who had a smooth socioeconomic transition and everything worked well for them. They all thought that this continuous communication, first of all, would be extremely helpful to identify veterans who suffer in silence, and they don't know where to go and where to ask for help, or they do not want to ask for help, but also an opportunity to show appreciation to all those veterans who dedicated a period of their lives serving in the military. So yeah, these were the some parts of the qualitative analysis, and we're moving on to our conclusions. Oh, Alex, you're on mute.
Alex?
Thank you. So we're just going to cover some key concluding points. So from the quantitative analyses, the first one is to highlight that the majority of ex-service personnel are in employment after leaving the armed forces, but there are some identifiable factors that may cause some difficulties in getting into potentially higher jobs. Which leads me on to my next point, that there are a number of factors that are related to socioeconomic transition, and this can be anything from demographic, military, in-service factors, and also health factors as well. And as you've previously seen, that age, for example, education, mental health, are all key factors that are related to positive and negative socioeconomic trajectories. And finally, this is a concluding point for the subgroups, that there is a common factor, age, that is affecting the socioeconomic trajectory outcomes, but it's having a different impact in all of the subgroups. And that's one of the sort of key takeaway points, that we find out exactly how these groups are being affected by age, what kind of challenges that age would pose, for example, for early leavers. Why is it that being younger might be a barrier to a more positive trajectory?
From a qualitative perspective, as I said in my first slide, this, let's call it objective, this objective negative and positive trajectories that we have identified in the quantitative component do not always reflect participants' perceptions and their subjective experiences over time. As we've seen, many people make a conscious decision to choose lower status jobs, or they end up in higher level jobs just because an opportunity arose, not because they were actually chasing such opportunities. Also, again, this point came from all our participants, is the importance of planning ahead, being prepared, being responsible about yourself and what you can achieve. All these were perceived as key facilitators for a smoother socioeconomic transition and overall cultural adaptation. And a specific point here about reservists is that the type of civilian job was perceived to impact quality of life during, but also after transition to civilian life. And more specifically is that working in the public sector or having a job similar to the military, such as being a policeman, these type of jobs were perceived to be very, very helpful during and after transition. I mean, during serving and during transition, as opposed to working in private companies. So, yeah.
So thank you very much indeed for that presentation. We're just about at the right time, which is good news. And so we're coming on now to the panel discussion. So we've got loads of questions, which is good. And I'll try and sort of distribute them out. I'll just take one just on the study we just talked about, which was, and actually it also links into advance as well, which is really about the impact of support. So we know there's lots of support out there for veterans. both for physically injured ones and for psychologically injured ones. What did the panel think in terms of the impact of support? Does it really make much of a difference in terms of people's trajectories? And the specific bits here is that maybe in the advanced study that the amputees maybe got more support than everybody else, and that might make a difference. And also in terms of the study we just heard about, it might also be that the physically injured get better support than the psychologically injured because it's a more obvious injury. So any thoughts on that? So please unmute yourself and jump in if you have an answer.
Do you want me to go first, or do you want Advanced to go first then?
No, that's fine, Howard. No, that'd be great if you go first.
Yeah, I mean, I think the support is definitely effective for all, for essentially every outcome. Depends exactly what we're talking about by support. When we're talking about socioeconomic transition, of course, we're often talking about support by the resettlement services. I don't know if anyone representing them is in the group today. I want to reassure them that the talk was not meant to be critical necessarily of the resettlement services. From all indications, they are doing an effective job at their main role, which is to improve re-employment of civilians, of veterans in civilian life. And yeah, that appears to be generally effective. It's more that there could be more to do with the cultural adaptation perspective, the teaching someone to be a civilian. I think almost literally with those words, Danai, nod if my recollections are correct, was brought up by transitioning veterans. I think social support in all regards is also helpful. We know that it's helpful for mental health. We also know it's helpful for employment, just in terms of having people to guide you to opportunities. I'm worried that I could talk about this forever though, so I might hand over to Nicola right now.
Thank you, Howard. Nicola.
Thanks. Yeah, I mean, I think based on what we know from the general population literature, then we'd say yes, support is important. And also from the work that we've done with the King's military cohort, we show that for those individuals that have good family support, good support from their chain of command and from their colleagues, do much better. So yes, I think support is really important, and that could be, and I've been following the chat, could be one of the factors that maybe is beneficial to our amputee group, that where we see this kind of lower levels of mental health problems. However, as we know, support changes over time. So I think as well, it's important that we don't just say, okay, it's all okay, we can kind of, down tools and kind of all go home. I think, we need to be following these individuals over time to see, well how does that support networks change, and does that then have an impact, positive or negative, on their well-being.
Great, thanks very much indeed. Got a question now actually for Kirstie. It's a sleep one. So we've done some work before, kindly sponsored by Blind Veterans UK, looking at the mental health of blind veterans. And the question is has there been any work done in terms of sleep with people who are blind? Is there anything different or that we should know about that you might know about?
Yeah, loads. It's been done in the 70s. It's old stuff, looking at if you're blind from birth, very straightforward, you don't have the light cue, so you can end up free running. In fact, if you stick all of us in a cave, we sleep for about 24 and a bit hours on average. But we get our time cues not just from light. So there's been mice studies looking at tiny doses, precisely timed melatonin, and many blind people sort of get in touch with our service and have found that out. But there is a really big difference about whether you've got some vision and light perception or not. So, yep, it comes back to sort of time cues and nuts and bolts of sleep. But low doses of melatonin and understanding your other timekeepers make a big difference.
Great, thanks very much. There's a question I can't find now, but it was one for Ron, just who's allowing one. Has there been any studies done to try and estimate the number of military personnel, military veterans who might have been affected, in a negative way by Lariam in the long term?
That's difficult to answer because the causation is the problem. There are obviously and we've seen the statistics of people with neuropsychiatric problems after deployment. But what the causes, was it MEFCON, or was it the deployment, or was it the trauma of the events that they face? So that's the big issue. So I suppose if you say that MEFCON toxicity and PTSD are the same thing, and some are caused by MEFCON and some are caused by environmental and occupational hazards, you cannot really separate the two. So does MEFCON cause long-term neuropsychiatric is still a question, and therefore you can't say how many people got it. You can do it when they have short-term, but you can't say it for the long-term.
Absolutely, I think that's actually very useful and a really good clarification that we shouldn't try and jump to make estimates when actually we're not entirely sure what it is that we're actually estimating. The next question I think is probably one for Nicola, because it's about injury, and it's about do you think that the legitimacy of the injury could impact upon psychological well-being? And particularly, that might say something about why the non-amputees and amputee groups were different.
Yeah, I think that's a really interesting point to consider, and ties in with some work that we did with family members of individuals who were wounded, injured or sick. And there we saw this almost hierarchy of injury. So it was kind of top of the list was to have a loved one with a physical injury that was visible. So for example, an amputation. Because people could then see that there was something wrong with your loved one, and maybe you and they needed some additional support. The kind of next level down was a physical injury that you couldn't see, but you could say, oh, my loved one's had a gunshot wound and you can't see it, but blah blah, and that was kind of the next kind of level down. And the kind of at the bottom of the pile was a mental health issue, and that was kind of you couldn't see it, people were uncomfortable sometimes talking about it, so I do wonder if there's some kind of hierarchy of injury that we are seeing within this group within the advanced study.
Great, thank you very much indeed. Kind of a slightly specific question is one for Howard. In terms of socioeconomic trajectories, how were people who decided not to go into a job, who retired and just wanted to go and fish or whatever they wanted to do, how were they classified? Was that a positive or negative?
They were classified as retired. So in short, didn't worry about them.
Okay, right, fine. So you assume that they retired and they were financially stable enough, and therefore we didn't look at them in detail.
That's the assumption, although we've had some interesting, very minor marginal work come through from Vets Check on that, but that's way outside the scope of this talk today. But yes, that is our assumption. I think that will largely be true.
Great. Okay,
Can I very quickly add something?
Please do.
Yeah, that was in one of the parts I didn't discuss today. So some people said that they could be retired because they have their pension, they saved money, they have bought their house, they don't have any financial responsibilities, but they decided to, for example, work part-time 1 or 2 days a week just because they wanted to be around people and offer back to the community. So I spoke to some people who could be retired, but they decided not to be, not for money, but just for their own pleasure, let's say. So yeah, so this could be classified as negative, even though it was their own choice and they didn't really have any financial issues. So yeah, that was
Great. Thank you for that. So the next question is a sort of more general one, perhaps, which is about the makeup of people working in military health research, particularly that our King Centre for Military Health Research team, and which says, are any of the researchers working on these projects veterans themselves? And it says this would seem to be important given the authentic insight into the questions that we're being addressing. So I guess for any members of the KCMHR team, I'll look at Nicola because you're one of the directors, so that's fair enough. What's your views on that?
Well, if I start off and then open it up to everyone else, but yes, I think that's a really valid point, and we actually work alongside serving members of the armed forces. So within King's, we have the Academic Department of Military Mental Health, and we have seconded military personnel that work alongside us. We work alongside them. It's great because we can give them the kind of perhaps some academic input, and they can help us with the kind of military input to make sure we're using the right language, etc., and can help facilitate access to the population of interest. And I mean, the advanced study, and Dan can expand on this more, the advanced study is embedded within Stamford Hall, which is a military base, and therefore, we work alongside military personnel as part of that work. And obviously we've got Neil, who is himself a veteran, who's part of our team. So yes, we do work very closely with veterans and currently serving personnel, and I think they're a great addition and give us great insight into this population.
Thanks, Nicola. Any of the other KCMHR staff got a comment on that?
Yeah, just to say that I will say that none of the team that spoke today are or have been members of the armed forces, as far as I know. But I would not regard that as a weakness at all, because of course we are seeking scientific objectivity in what we're doing, and investigator bias, as I'm sure the scientists here will know, is an ever-present and pernicious problem. Really difficult to pull apart one's subconscious preferences from individual experiences and how they might affect both the analysis that you do and the interpretation that you put on it. So I don't regard it as a weakness, but of course you're completely right to say that that has the problem that we end up in an ivory tower. So our solution to that is, as Nicola has said, to work alongside other members of the department and ADMMH to try to have their input. But also for this, we also had a panel of veterans, and all of the findings, I think all of the findings that you saw today were previously put in front of the eyes of empanelled veterans. As well as, of course, drawing from qualitative interviews from veterans. And they all said that it was very sensible and that, yeah, it all added up with their experiences. So, yes, we do cross-reference to make sure that we do break out of our ivory tower.
Great, thanks very much indeed. Got another question for Kirstie now, which was about, it would be great to hear a little more about sleep deprivation and memory formation. And I think I can add my twist on that is might that make a difference in terms of troops who are deployed? If they're sleeping poorly, might that do something to the way that they might sort of lay down memories about the traumatic experiences that they might have?
Yeah, absolutely. So it's really interesting. So the bottom line, of course, is young troops are robust and sleep far better than me. You know, you sleep at your best between 16 and 25. So they are resilient and withstand sleep deprivation better, in fact, than older people. But if you interrupt sleep, particularly within 90-minute cycles, you have an immediate impact on recall and on memory, and that, you know, that's very straightforward. It's robustly demonstrated. So it's absolutely worth looking at the timing and the dose and the chunks of sleep and the recovery. There's interesting work from the Oxford group looking at what is good and bad about sleep if you've had a trauma, and going back to, in fact, might it be a good idea not to sleep too deeply after trauma? There's a real debate about this, rather than giving people, you know, sleep, in fact, consolidating a trauma memory. That may not be a good idea, and that's sort of debatable. And you know, the plan of actually going out and having a great deal of alcohol might be a really good plan, because it's really memory disruptive, and that may not be, I'm not recommending it as a prescribed treatment, but there are things that groups of people do after bad things have happened that intuitively might make sense to them, and in fact may have a role in disrupting unpleasant memories. So most young people recover sleep debt quickly and can have short periods of sleep deprivation without affecting their daily function. But yes, there is a rule in what happens to your sleep after a nasty trauma, with some debate that in fact too much sleep or enhancing sleep straight after the trauma may not be good for exacerbating post-traumatic stress.
Okay, I think that's really interesting, actually, and it's actually something for the operational side of the team to think about. Certainly out in deployment, what you tend to get is in the forward, more austere places, it is more difficult to sleep for lots of reasons. But actually, we don't find the hugely elevated rates of PTSD that you might expect. And it might be that actually, because they don't sleep well, they actually might be protected to some degree. Whereas in the main base areas, I guess, where they do sleep better, actually, it could be worse off. Anyway, an interesting view for the future. Well, listen, thank you ever so much to all of our speakers for putting in the effort to prepare for that and for delivering. It's been, I think myself, been a great morning. We will ask you, if you anyone who's still listening, and I see people are, which is great. We have got in the chat a feedback form, and we'll hopefully email that out to you as well. So we'd really like to know what you thought was good and what wasn't. And it just leaves me to say that next week we have our next session, which is being chaired by Nicola. So I'm off the hot seat, which is good for me, and that's on veterans, families, and COVID. And so that will be again at 10 o'clock till 12 o'clock. And if you haven't registered and would like to, then if you can do that on Eventbrite, and you can look up the kcmhr.org website as well. So thank you very much for listening. I hope you found that useful, and have a good rest of the day. Thank you very much.